Thank you very much for the introduction. And today's talk is a bit inspired by discussions I had at the Charité Global Health Day, where people were talking about the need to justify global health projects towards funders, towards policymakers, repeatedly getting the question, why should we do that? And then somehow the question arose, okay, so what if we implement a project? What if we start a research project? What if we roll out an intervention? And maybe the even more important question when looking at disease outbreaks, for example, at lack of universal health coverage, one of the even more important questions may be, what happens if we do not do that, right? So what if we don't invest? What will it cost us? What in terms of money, but also in terms of quality of life, lives lost, disability adjusted life years lost, if we do not take action. So this is how we came up with this topic, or how I came up with this topic, and thought, okay, maybe that is something to contribute to the GLOHRA community, to give an idea at least of what might be possible with health economic evaluations. So since I know that we have a very mixed audience today, as usual, I believe, I would like to start with a brief, slightly superficial, but hopefully sufficient introduction to the idea of health economic evaluations. So first of all, I would like to give a brief overview of what types of evaluations there are and what types of outcomes they involve. I would like to say a few words about what model-based evaluations really are. So what distinguishes them from some, for example, impact evaluations. Then say a few words about uncertainty. And there are two major types of uncertainty in modeling, which are scenario and model uncertainty. And finally, to enter the discussion, or to give a first input and then maybe inspiration for the following discussions. How can that help in early stages of global health projects? So first of all, the question, what are health economic evaluations? What are they meant for? And the main purpose of these evaluations is really to guide decisions about funding, for example, about reimbursement decisions, about whether or not to start costly policy interventions. So if we do it model-based, before the actual intervention, the idea is really to say, okay, what are the alternatives? What are the benefits? What are the costs? And if we look into the more traditional type of evaluation, you would say, okay, after you implemented something, what came out? What were the costs? What were the benefits of that? Were there benefits, or did it maybe turn things even to the worse? And then decide whether or not to scale up, to do it on a broader scale, or to continue such a program. So basically, it's about decisions about funding, about resource allocation. Should we do something? Should we not do something? And the different types we distinguish in health economics are, first of all, cost effectiveness analysis, which is probably to those from the medical field the most self-explanatory thing, because there we look, of course, at the cost. We want to know how much does a unit of effect cost us. But here we measure the effect in real, measurable, observable natural units. That can be life saved or life year saved. That can be reduction of blood pressure in millimeters Hg. That can be avoided infections. That can be additionally identified cases when evaluating new tests. The advantage is that the outcome is super simple to measure. It is totally clear what you're doing. The disadvantage is that you can only have that one dimension, and that you can only talk about this one dimension. So the second thing health economists came up with was cost-utility analysis, where we still measure the cost per unit of effect, but now we use a different concept to measure the effect, which can be something that's evaluated on a scale like quality-adjusted life years, averted disability adjusted life years, quality of life scales. So what we do then is we try to turn the health outcome, the effect of our intervention into a score, into a scale that includes not only the hard clinical outcome, but also involves quality of life and the utility that people gain through that intervention. Finally, and that's, I think, most appreciated among economists, but also the most challenging thing, is cost-benefit analysis, where you say, now we would like to see the net benefit in monetary units, which means we take the health effect, we try to understand the quality of life, the utility people take out of this, and from this we find out what is the willingness to pay for that health effect. And then we say we want to know the net benefit, which means we try to find out how much is it worth to people in monetary units, and we subtract the cost for it. And if people are willing to pay more than it will cost us, we say that's a good thing, we do it. And in general, with health economic evaluations, we want to answer three major questions. The first is, what does it cost us? And that's possible with all three: cost effectiveness, cost utility, and cost benefit analysis. All three will tell you what were the cost of the intervention, of the new technology. All three will give you some kind of allow you to assess, is it in the budget? So all three will tell you what is the cost, what is the effect, can we afford the measure? But only cost-benefit analysis, but that's more of a side note because it's really tough to do because you need a lot of information, but only cost-benefit analysis can tell us, is it worth it? So will really tell us, does the willingness to pay exceed the costs? And if it does, we say it's worth it because people are better off with that measure. And if it doesn't, we know that people are not better off or even worse off if we implement this, the new technology or the new policy measure. Okay, now a few words about what are we talking about when we're talking about model-based evaluations. And first of all, to distinguish the two. Impact evaluation is what we do ex post. So after we implemented a new technology, after we started a new policy, we rolled out a policy measure, a preventive measure, you name it. We want to know what was the effect or the effectiveness, and we want to know what were the cost. So if we look at impact evaluation, we do it after the measure took place, we do it after the technology was implemented, and we look, how did it go? And then do we continue, do we scale up or not? That's lots of statistics, lots of econometrics, and very important. But what I want to talk about today, or what I would like to discuss with you today, is the idea of model-based evaluation. And there we say we do it ex ante, we do it before we start something. And the two questions we want to answer with that is, first, what if we do it? But also because economists always look at trade-offs, compare scenarios, and try to find the best solution, which can be do nothing. That would be the question, what if not? That could be change something, implement a new measure, and that would be a projection of what if. So the idea behind all this is we want to inform, we want to inform decisions about policy interventions, about public health programs, new technologies. We want to make sure that decisions, whether or not we try them, are based on a rational projection of what the future or what they may or may not bring. So in other words, we want to say, instead of a gut feeling, modeling uses strict math to make informed, well, still informed guesses, but now following strict math instead of a gut feeling. It also allows us to give a point estimate, a clear estimate, with confidence intervals, with a defined uncertainty of our projections, predictions, And that will be probably more precise than a rough estimate, like looking at the numbers and just making a guess out of the blue. It is clear that this approach relies very strongly on the available information. That means we have to look into earlier evaluations, into the literature, maybe into feasibility studies to make sure that we really have proper assumptions, proper values that we're working with. So it's very clear to understand that all models are only as good as the information they're based on, right? So it can only be as good as what we use to build the model. Then when we look at those modeling approaches, there are three different classes or types, I would say. The first, most simple one is decision tree analysis, where you basically compute estimate expected values, expectations for the different alternatives you have. These are great if you want to see what happens if you implement a new test or if you add a new testing strategy into an existing national screening program, for example. So use an additional test, which will cost money, but maybe identify additional cases. What is the expected effect? What is the expected cost? It's fairly easy to compute, but it's only suitable for comparatively simple cases or when you really know what is going to happen. The second class are, let's say, models that predict different decisions, different behaviors over time. And state transition Markov models are a good example for that, because they can model they can model behavior over time. So one example I will say a few words about later is when you say you have different approaches to keep people in compliance with a certain treatment over some time, over 1 to 3 months. And they can drop out of the treatment at any time, and you have different approaches to kind of keep them tuned in your program. Then this is one approach you can do with which you can do this. It is still not super difficult to compute, but it's a bit more complex than the easy decision tree models. One disadvantage is these models have no memory, which means it only matters where you are, what happens next. It doesn't matter where you came from, right? So you cannot build up health risks, for example. And for that type of modeling, you would use something like microsimulation, where you say, okay, I build up, for example, risk for lung cancer with each additional month I'm smoking. And the huge difference is with Markov models, you would estimate cohorts, whereas with microsimulation, you will simulate individuals, and these individuals, as I said, can build up a memory. They can collect risks or benefits. They can collect wealth or debts, all that, and all this would not be possible in a Markov model. Now, as I promised, I will give 2 examples for these modeling approaches. This one is taken from the literature, from an editorial, and there it was about whether or not to implement, or better to say how to screen for tuberculosis. And the comparison is GeneXpert versus sputum smear microscopy. And what you see here is you always say, okay, you want to know what are the costs and what are the effects. So let's say someone with tuberculosis has a certain in a population, people have a certain probability to have or have not tuberculosis, and then to be identified correctly, or missed positive cases to be correctly identified as healthy, or to be falsely considered as ill, although they're not. For each of those cases, you say that will involve costs for testing, but also for the patient, and that will lead to a different health outcome or health utility outcome. In that case, it's disability adjusted life years. Treated tuberculosis will have a better outcome than untreated tuberculosis. Untreated healthy people will have a better outcome than healthy people who have to go through the tuberculosis treatment. But for all this, you need a lot of information already, which means you need to know about the sensitivity, specificity, prevalence of tuberculosis, the costs, and also of the health outcomes of treated, untreated tuberculosis, potential side effects of the treatment. So as always in modeling, the information can be taken from the literature or from feasibility studies, which means if you have some reliable information, you can start computing these models, and this is really just computing expected values. What you do is you predict the whole cost and the whole outcomes of the different alternatives, and then just compare what is more costly, what gives you more health outcomes, which one is in the budget, which has the better cost to effectiveness ratio. So what you do is basically, you simply compute the expected values. The second example I promised comes from a Markov model. And here, this is a model I computed with two co-authors. It's an example from Germany, but you could do it the same way for any country in the world. And the idea was to simulate what happens if we include decision support systems. So really active nudging by an app into an app for treatment of low back pain. So the idea was there are already some apps out there, but the problem is that people about their treatment. So the idea is you can have low or high back pain, and either you just endure this or you enter treatment. And if you enter treatment, you can stop your treatment after each of those 4-week periods, right? So you can say, okay, after this time, I feel better, although I'm not healthy, or I have problems with that app, so I just go back to my low or high back pain state. Or you continue treatment through the next 4 weeks and the next 4 weeks, and you can only reach a healthy state if you complete the whole treatment. Now with modeling, you can say, I change the assumption about these arrows. I know from the literature that maybe 30% usually stop treatment, but I know from other literature that those nudging systems in other contexts increase adherence or compliance with the treatment by, let's say, 10 percentage points. So you say, okay, then the dropout rate drops from 30 to 20%. What would happen if we achieved that? And then you run the model under the new assumption without having tried it in advance. And this again will give you, for different assumptions, for different scenarios, will give you different costs and different health outcomes in total. And then you can again compare and see what is the cost effectiveness or the cost utility ratio of the different approaches. So just to give you an idea how those Markov models work. Okay, maybe a few words about uncertainty. So there are the main two types of uncertainty. One is model uncertainty, which means we have maybe a lack of precision in the input parameters. We don't know exactly what the dropout rates or what the sensitivity, specificity costs will be. That will induce model uncertainty, because with an imprecise assumption, we can only make imprecise predictions. But that's true for all measurements and all samples you will ever come across. There is no perfectly exact measurement. That just doesn't exist. One problem is that these uncertainties add up. So a potential solution to do that may be simulation if you have a complex model, which is commonly done. If we talk about scenario uncertainty, we still have model uncertainty, but then we also don't know exactly which strategy will policy choose, which of the different scenarios will be implemented or not implemented. So if we make projections and we don't know the scenario exactly, we have the scenario uncertainty. If we go back to the step, we want to use those evaluations in an early phase, we define the scenarios and say, if we implement our project like this, this is going to happen. If you do nothing, this is going to happen. If you do something else that you suggested and we think it's not a good idea, this will happen. Communicated in a more diplomatic way, but that's basically what those comparisons of scenarios can do. And then just to throw this term into the discussion, so-called probabilistic sensitivity analysis combines to some extent model uncertainty and parameter uncertainty and scenario uncertainty together. So that's a different topic would fill another complete Academy Series event, I guess. Okay, so to wrap it up, how can this help us in global health projects or in early global health projects? Well, as I said in the beginning, some discussions in the community indicated that the need for justification is increasing. The less funding we have, the better we have to justify why we spend money and on what. So one of the typical questions is, why should I fund this? What is going to happen? If I do this, how will it benefit? And one thing we always have to keep in mind, a relevant part of the answer is what happens if the project does not happen, if we do not prevent infections, if we do not increase universal health coverage. What will it mean for the population there, but maybe also what will it mean for international relations? So when we're planning a project, and then it really depends on the aims and scopes of the project, very different ideas or very different modeling approaches, modeling scenarios can be used. So we can model infectious disease outbreaks and compare different policy measures or different interventions and try to predict what our project may hopefully help in the situation. We can think about something like insurance uptake after policy interventions, which would call for a more complex model. Think about compliance of patients in remote areas, which would be related to the mHealth, the back pain app example I gave you. But also think about healthcare utilization patterns if you increase or decrease access to care, and even think about preventive behavior. If you say, I know from other contexts, people will change their behavior like this if we offer that. So let's see what this early observation would contribute in a different context and just model this. Yeah, so the good thing is, or the advantage when writing a proposal is, we have to find the literature which includes all the information we need for a model to justify our project, to justify our proposal. That's what we usually do. So my idea, my suggestion is use that information to build a systematic model to try to make a prediction as precise as possible. Because first of all, it can simplify your efforts to convince your funder or to convince your policy partners in the country you're working in. And second, it will also help you to really make sure that you have all relevant information and take everything into account that is going to matter for your project. Because if you build a complete model for prediction, you are more likely that you do not miss relevant information and that you do not end up with unpleasant surprises in the course of your project later on. So these are my ideas how this can help in early stages of global health projects. First of all, sort out the information for yourself. Second, have a more precise, more clear projection of what to expect from the project, which you can communicate to policymakers, potential funders, project partners. And then I would like to conclude with the Global Health Research is slide. And I'm not going to read it out to you, just about my motivation. I tried to define global health for myself and then thought everything is either too narrow or too broad. So I decided I don't say global health is as a definition of a subject, but what it means to me. And I would like to thank you for the attention.